so very much, first and foremost, for those who are coming from outside of Hawaii. Welcome to this lovely state. Being a person from Georgia, I came here and just went like, wow, I wish I was born and raised here, you know. In terms of, for those who are from Hawaii, I just really appreciate you guys taking time out of your busy schedule to partake in this symposium. I think such an important thing, and we, as an aside, as a clinician working here at Queens Medical Center and working with our nurse practitioners, I just see the value of just what our nursing staff and our nurse practitioner staff, what kind of impact that they have on clinical care. And we would not be who we are without these individuals. And so just a round of applause goes out to our nursing staff and nurse practitioners. So I'm going to share a little bit of something that's near and dear to my heart, which is acute stroke care and in relation to mechanical thrombectomy. And just kind of the story behind which at one point in 2013, there was the low point where the death of ischemic stroke from thrombectomy standpoint to now a rise and rebirth of that. And I want to share that story. A little bit about myself. The reason why I went into the field of neurology and stroke care is that when I was a high school student, I visited my grandparents in South Korea, and I was visiting my grandfather, my mother's father, at his home, and I noticed that when I got there, that my grandmother was feeding him some rice and kimchi using chopsticks and feeding him. And at that time, I could see that he had his right side of his body was weak. He had slurred speech, and he was choking on his food. And at that time, I didn't know what was going on, what had impacted him so much that it was causing him such disability. And it was later in medical school, I realized in putting it all together that he's an Asian male who had smoked his entire life and had all these risk factors for cerebrovascular disease, probably had a left MCA stroke that left him with some language issues, right hemiparesis, and ultimately what he succumbed to from an infection from probably aspiration pneumonia. And so this is what caused me to kind of open up my mind to saying, you know, what can we do about stroke care? What can we intervene? How can we help those individuals who suffer from acute ischemic stroke? So disclosures, I'm part of the HEAT trial, which looks at hydrocoil gels and treatment of aneurysms, and that's still an ongoing study. This is a phoenix. The phoenix is a mythological creature that has been utilized by actually early Christians as a creature of the sun, that in death from the ashes, there's a rise in new life. And hopefully during our lecture today, we'll get to see how ischemic stroke therapy, especially mechanical thrombectomy, is represented by the phoenix. Our goals today are to review the evolution of mechanical thrombectomy and the reasons for the past negative trials and results. And then also review the current level 1 grade A evidence for mechanical thrombectomy, and hopefully share some practical guidelines in determining which stroke patients would benefit most from mechanical thrombectomy therapy. So I want to share a case with you. This is a patient that I saw in the hospital. Dr. Nakagawa was actually the individual who was the code stroke attending at the time, and he called me up. There was a 56-year-old female with atrial fibrillation and acute left leg pain and numbness that got admitted to the hospital. And this is her CT angiogram reconstruction of the pelvis, and what we're seeing, and I don't know if, is that there's paucity of the common femoral vessels here. And what this individual had was an acute clot within the common femoral artery that required thrombectomy from the vascular surgeons. So the patient had a successful left superficial femoral artery thrombectomy by vascular surgery, was placed on heparin drip, and on post-op day number 1, patient developed acute right hemiparesis and aphasia. So clinically, the patient's having a left MCA syndrome. Dr. Nakagawa was called immediately to the patient's bedside and seeing what was going on, also concomitantly called me as well. Patient went to CT scan, and the non-contrast CT shows a hyperdense, and if I can, there we go, hyperdense left ICA sign here. rather than going and spending more time doing a CT angiogram and the high acuity and the clinical picture, the decision was made, let's do something about this. So what are the options? Well, the patient has what appears to be a left MCA syndrome, hyperdense left MCA. What are our options right now? Well, everyone should always consider IVTPA as always in the background. These are the algorithm that we think about. Remember the NINDS trial that came out in the 1980s and the ECAS3 that came out in the late 2008. These show that the efficacy and benefit of having IVTPA for acute ischemic stroke from at least the NINDS trial within 3 hours of onset of symptoms, and with the ECAS3 showing that the window can be as wide as 4.5 hours. However, this individual that we were dealing with had two major contraindications. Number one had acute surgery, and number two was on a heparin drip. Both are considered contraindications for IVTPA. So what are the other options? What about endovascular intervention? And we're going to look at one of the endovascular intervention, which is IA thrombolysis. So IA thrombolysis is actually placing a microcatheter near the clot and infusing a thrombolytic agent. One of the major trials that was done in 2003 called the PROACT-2 trial. And this was the study, this is the hallmark trial for showing that when you are able to identify an acute thrombus within a large vessel like the middle cerebral artery, and this trial looked just at middle cerebral artery occlusions, and you were able to infuse pro-urokinase and get recanalization. They showed that at the 3-month time point, looking at modified Rankin scores of how they're doing clinically, that there was a definitive clinical benefit. The unusual thing about this particular time period was that even despite showing clinical benefit, the FDA did not approve a pro-urokinase for IA delivery for acute ischemic stroke. And so that was kind of a setback. And the FDA's reasoning were at the time was that they wanted more trials. Show us more data, and once you've shown clinical efficacy beyond just one major study, then we may consider it. Unfortunately, doing these intervention trials are very difficult, costly, and no really future further follow-up was made in that aspect. What about the actual mechanical thrombectomy, the art of actually physically pulling the clot out rather than trying to thrombolyse the clot? So this is actually the first generation mechanical thrombectomy devices. It's called the Mercy device. And as you can see, it looks like a small little corkscrew, like imagine a wine bottle opener. And the goal is to place a microcatheter through the clot and then unravel this corkscrew-like wire with some filaments that will hopefully adhere to the clot, and then you can slowly pull the clot out. And the Mercy clot retrieval device was shown to be efficacious in recanalizing the vessel. The early studies show anywhere between 50 to 80%, depending on what studies you showed. But they did not show, at the 3-month time point, the clinical benefit that one would hope to see once you get recanalization. Interestingly, however, unlike the pro-urokinase trial, the PROACT-2 trial, where they showed clinical benefit but no FDA approval, mechanical thrombectomy did not show clinical benefit but got FDA approval for the indication of recanalization. Not stroke care, but recanalization. So it's a little bit odd, but that's how I think sometimes some of these device manufacturers are able to get approval, is that they get an indication despite not showing clinical benefit. But we knew in the field of neuroscience that if you have someone who has an acute stroke and they have blockage of the artery, the goal is let's open up that blocked artery. And so that perpetuated the goal of, well, let's try it. How can we more easily do this? How can we do it more quickly? So the next generation of catheters came out called the Aspiration Catheters. This is a set of catheters from Penumbra. And the goal is, you can imagine, you place this big tube to where the clot is, and you see this little wire with a bulb. That bulbish wire moves back and forth, macerating the clot, and you're hooking up that tube to suction, so you're basically vacuuming up the clot. And that was kind of the second generation thrombectomy devices. Third generation is now where we are really at right now. It's called the Stent Retriever. And this is where you're actually delivering a stent that looks like literally a rolled up chicken fence wire in a tube. And you deliver the microcatheter to the clot, and you unsheath the stent through the clot, and you can see the clot adhering through the interstices of this stent, and then giving about anywhere between 3 to 5 minutes, letting that clot incorporate along the wire mesh, then you slowly pull that clot out. And that really has been the game changer, where we can see recanalization rates as high as in the high 90%. Okay. Well, we're all very excited in the field of interventional neuroradiology, neurosurgery, neurology. We're very excited because we're seeing all these great outcomes happening. And 2013, the International Stroke Conference was held here in Honolulu, Hawaii. And 3 major acute endovascular stroke intervention trials were presented at that meeting. And that was going to be the late great game-changing trials. And they were going to present that, and we're highly expectant. Much of the people did not know the results. And International Management of Stroke trial number 3, where they compared IVTPA versus partial IVTPA and mechanical thrombectomy, negative. Synthesis, IVTPA versus mechanical thrombectomy, this is an Italian study, negative. Maybe if we figure that we use some kind of imaging like CTA or MRA or perfusion studies, that we can better select patients to see who would better benefit from mechanical thrombectomy, MR rescue, negative. So we were left at this editorial at the end of the International Stroke Conference with Mark Chimowitz, who's one of the lead authors. He's now at MUSC. Is endovascular stroke treatment unproven? And the thought was that the mechanical thrombectomy was now in its ashes. It has died. It's no longer something that we should be doing. And this was such a disconnect from what we were seeing in actual practice, because in actual practice, you have patients that would come in with acute M1 occlusion or internal carotid artery occlusions, and it's a large clot burden. And the issue with giving IVTPA was that when you give systemic IVTPA, IV thrombolysis, is that it may not be adequate enough to be able to break that clot so that you get recanalization. What happens then is that if you go in and physically pull that clot out, they have resumption of flow, and they have a better outcome. That's what we were seeing in a clinical setting. And there was such a disconnect between the trials and what we were seeing in practice, and a lot of us were kind of at a place where, like, were we wrong? What did we do wrong here? Well, the study concerns were manyfold. Number one, the studies that were published at that time utilized older generation devices, the Mercy devices, the devices that had lower recanalization rates. And also the time by which the time it took to recanalize these vessels were also much longer. The IMS3, which was the International Management of Stroke 3 trial, that was the big one. We also noted that in the arm that did get mechanical thrombectomy, we felt that they were getting lower dose. Rather than the 0.9 mg per kg IV TPA dosing that they were getting in the standard arm, they were getting 0.6 mg per kg. And so the question then becomes, well, are you starting behind the start line when you are in the mechanical thrombectomy arm by giving a lower dose TPA? And that also in many of these trials, especially the Italian study and also the IMS3, those individuals who got randomized to the endovascular arm, not all of them had proven large vessel occlusion. So it could have been a lacunar syndrome or so forth. Those are small vessel perforating branch strokes. And so mechanical thrombectomy wouldn't help in that situation. So with all these things, there was a lot of concern about the validity of that trial and how it really represents what we're doing in clinical practice. So let's look at IMS3, for example. So in the IMS3 trial, we can see that the total dose of TPA given in the endovascular arm, that's the side on the left column, was lower than the IVTPA alone. Time to onset of groin puncture was almost 3.5 hours. So already there's a pretty significant delay in terms of, right now, our current practice, with the team that we have here, when we get an acute stroke code activation, we're concomitant to activating not only the team that's going to evaluate for IVTPA, the endovascular team is also being activated as well to be on standby. And when the patient goes for CT scan, they're giving TPA in the CT scanner, and then you get a CT angio, and there's a large vessel occlusion. We're going to take them to the angio suite. We're groin, door to groin can be less than 30 minutes. And so you're talking about 3.5 hours. That's the individual's brain holding its breath underwater for 3.5 hours. So you let me know if that's going to have an impact on their ultimate outcome. Also, 20% of patients in the endovascular arm, if they did get multimodal imaging like a CT angio or MRA, had no clot to begin with. And so you're kind of putting in patients that's going to water down the potential results of mechanical thrombectomy because they didn't even have clot in the first place. And lastly, the time to onset of IA therapy. So one was talking about actually groin puncture, but there are centers that require a large setup, getting the special catheters up, and so forth, and ultimately look at 4.2 hours of actually getting the therapy completed. That's a long time. So when you look at the IMS3 supplemental data, and I apologize for the detail and also the small font in this, but the point I'm trying to make is this, is that when you actually look at when you look at patients who actually had IVTPA less than 120 minutes and also got IVTPA to groin puncture less than 90 minutes, the point is that if you look at the subset of patients and you select out those who are able to receive therapy quickly, we see that on this is the bar line. Anything on the right side shows benefit of endovascular therapy. On this side shows IVTPA is better. And you can see if you were able to give IVTPA quickly and get endovascular therapy quickly, there is benefit to endovascular therapy. When you look at the CTA proven occlusion patients, so if you just selected out all the patients in IMS3 and you said, did they have occlusion or not? And those who had occlusion, and you then differentiated IVTPA alone versus mechanical thrombectomy, there is a clear benefit endovascularly. Endovascular treatment has clear statistical clinical benefit over IVTPA alone. And you can see that the MRS, you can see all these patients starting to stack up towards the no disability to minimal disability to mild disability that with capability of taking care of themselves versus just IVTPA alone. And it's at clinical significance of 0.0114. That's pretty darn good. So out of the ashes, you have this new rise of this phoenix coming in January 1st, 2015. Mr. Clean, not the guy that cleans the toilets and the bathroom, but this is a study, MR Clean was a study done by the Dutch government where they looked at patients with acute ischemic stroke with proximal intracranial occlusion. And they were given mechanical thrombectomy therapy within 6 hours of stroke onset. And it was shown to be effective and safe. So the goal is, we talked about IVTPA being 3 to 4.5 hour window, remember? And then we said prourokinase was clinically effective but not FDA approved up to 6. Mechanical thrombectomy in this particular trial was looking at all patients within, if you can get them to treatment within 6 hours, this is the goal here. And this, Mr. Clean, which stands for Multi-Center Randomized Clinical Trial of Endovascular Treatment for Acute Ischemic Stroke in the Netherlands, it was shown to be highly efficacious in large vessel occlusion. What they shown was that when you looked at the outcomes, modified Rankin of 0 to 2, 0 being no deficit, 1 being a mild deficit, 2 being something that may impact their work, but they're able to ambulate and do the normal daily activities of daily living, show that 71% improvement over medical therapy alone. Mechanical thrombectomy was 71% better than just IVTPA alone. Okay, so 32.6% versus 19.1% reaching MRS 0 to 2 respectively. So again, you can see on this shift analysis that in the intervention, mechanical thrombectomy versus the control, this is TPA, this is endovascular, you see it, I mean, you and I can look at this and go, wow, look at modified Rankin of 0, 1, and 2 versus TPA alone. And so this was a trial that said, why was there such a difference in this trial versus all the other trials that were done? Well, first of all, I'm going to say that they've shown benefit in patients of all ages, even patients older than 80. There was really no significant difference in adverse outcomes. And this is the key thing. The Dutch government did not pay for the intervention unless patients were enrolled in the trial. What that means is that in the U.S., what we figured out was that when a patient comes in, let's say they're 36 and they have a left M1 long segment occlusion, and they were given the opportunity to say, should we enroll this person in IMS3 trial? And the doctors would say, no, we're going to just go and do this. Because they felt that if they enrolled this person and they got, let's say, randomized to IVTPA, then they would lose the opportunity to potentially help that patient. And so there was cherry picking of patients in the US studies where the Dutch government said, we're not going to have any of this. We right now have equipoise. We do not know if mechanical thrombectomy helps patients or harms patients. And so for us to actually pay for this treatment, you have to enroll them in the trial. And so 100% were all within this government design trial, and all patients had proven arterial occlusion, and they used the latest devices, these Stent Retrievers, with high recanalization success. And since that time, guess what? In that same year, 5 positive trials came out because they all utilized the newer generation devices. They had a lot shorter time to recanalization. So time from door to IVTPA, door to groin puncture, door to recanalization were significantly improved, number one, because technology has improved, the systems of care has improved, and the focus have all changed so that they can also differentiate what patients would most benefit from these therapies. And with that, mechanical thrombectomy, the number need to treat was about 2.5 to 7 patients. Compared to IVTPA, the first NIDS trial, number need to treat is about 8 patients. The ECAS-3 is about 16. And so even though IVTPA is beneficial, mechanical thrombectomy in the right patient population is highly efficacious. So, and then in terms of the flip question is, well, what about, is there any additional harm? When you compare all the 5 New England Journal of Medicine trials that came out in 2015, and you look at the endovascular arm, where is the point? Endovascular arm versus the control, you can see that symptomatic intracerebral hemorrhage rate is not statistically significant. Parenchymal hemorrhage is not statistically significant. There may be a slight rise in subarachnoid hemorrhage, but in terms of 90-day mortality, was not statistically significant. Actually, it was lower in the endovascular arm than IVTPA. So let's go back to that case 1. So this is the patient that had atrial fibrillation as a cause of the clot in the leg, that the vascular surgeon removed that clot. And during the hospitalization had a clot now projected into the left internal carotid artery. This is a cerebral angiogram AP view of the common carotid artery, and what we notice here is that you see the external carotid artery branches, and the internal carotid artery has a arterial cutoff at the level of the petrous ICA segment. My goal was to place a big, large guide sheath, a microcatheter, guide catheter and microcatheter beyond the clot. I have a micro injection to show that there is antegrade flow within the distal M1 segment beyond the clot. And then I deployed my stent, and you can see the tines of the stent from here all the way. So this, from this point to this point, represents the clot burden. And we pull the clot out, and then we have complete recanalization. You get the goalpost touchdown. So, what we saw was this. When we pulled the Stent Retriever out, this is the clot that we pulled out of that individual. That following day, the patient got a MRI, and the MRI shows a small little diffusion abnormality in the subcortical white matter on the left side. Patient by the second day was clinically completely neurologically intact. So the patient went from an NI stroke scale of 28 to 0 and was discharged. So this is what we were seeing from a clinical perspective. Again, this is a person probably who had great collaterals that were able to continue to maintain prenumbral tissue that was asleep but not totally dead. And it gave us enough time to be able to pull the clot out without a large ischemic changes. So what are the things that we can do to better define who are the patients that we should be considering mechanical thrombectomy? So after the 5 New England Journal of Medicine papers came out, the American Heart Association came out with new guidelines. So in 2015, the AHA guidelines, and I want to highlight this interesting fact. This guy, he's the chair of this writing committee. He's the chairman at University of North Carolina for the Department of Neurology. And he was the guy, after the 2013 3 negative trial presentation, said, basically, ischemic stroke mechanical thrombectomy therapy is dead. It's unproven. We should not be doing it, period. And after the data came out, you know, you cannot argue with data. When it's done properly and has shown to be robust and is reproducible, he said, you know what? I want to chair the writing committee for this guideline because I want to be the first to say when I can see that the information is correct and done properly, I want to be able to voice that and change the minds of my colleagues. And so he wrote this, and the recommendations are now is that, number one, patients should be considered to receive endovascular therapy with stent retrievers, and actually the Society of Neurointerventional Surgery has added also aspiration therapy if they meet the following criteria. The following criteria are, so their pre-stroke modified Rankin of 0 to 1. Our institution actually goes to 2. That means that if a bricklayer has a facial droop, that's a modified Rankin of 1. If a newscaster has a facial droop, that's a modified Rankin of 2 because it impacts their work. We feel that in our institution, we kind of said we want to be a little bit more lenient to capture the patients that would still benefit. So we have a modified Rankin of 2, but the current guidelines are MRS 0 to 1. That they have acute ischemic stroke, and that you should never bypass IVTPA if they can receive it. So don't bypass IVTPA, but you're doing things in parallel. And the cause of the stroke is a proximal internal carotid artery or a large segment M1 occlusion. They're over 18, and an NI stroke scale equal or greater than 6, and an aspect score greater than 6. Now I'm going to show you what that aspect score is also. And that treatment can be initiated. So groin puncture can be initiated in these patients less than 6 hours, okay, or within 6 hours. In terms of if endovascular therapy is being contemplated, it's probably practical to get intracranial vascular imaging like a CTA. MRA is a little bit more cumbersome, but just knowing that there is an occlusion to go after does help your interventionalist plan for that strategy of attack for treatment. So aspect score. The aspect score is an Alberta stroke score that was developed by our Canadian colleagues. And the goal is that you divide up the brain in 10 parts. You have the ganglionic level. So why is my pointer? Okay. So you have the ganglionic level, so caudate, internal capsule, lenticulostriate, lentifold nuclei, I should say, and then you have the 6 branches, 6 segments of the middle cerebral artery territory, 1, 2, 3, 4, 5, 6. And in the area that has hypodensity, you deduct a point. Okay, so if it's someone who comes in acute stroke and their brain looks completely normal, all those areas don't have hypodensity, you didn't lose a gray-white differentiation, then they should have an aspect score of 10. If you find that they have a area that's all blurred here, here, and here, but everything else looks fine, they would have an aspect score of 7. So the recommendations are if you have an aspect score of 6 or greater, then that should help kind of draw a line image-wise who would benefit, because there's no point in doing mechanical thrombectomy if you have a large area of infarct or dead tissue, right? Also, something that we have incorporated in our institution is using the collateral score. The collateral score is that you can see from what's called maximal intensity projection imaging or MIP imaging on your CT angiogram. This is where they stack all the little slices on the CTA, and you can almost see all the branches as if you're just looking at like a standard angio. And in this situation, what we see here is that when you have a proximal, let's say here, this individual has an IC occlusion, or you don't see the MCA at all. And then when you go further up, you see there's no collateral or no other branches that are lighting up. So this individual, if I were evaluating them, let's say they were coming from an outer island or neighboring island, and they sent me the CTA, and it's going to take us an hour and a half to transfer, I would probably say to the transferring doctor, I would say, we probably could recanalize the vessel, but us being able to benefit this patient with recanalization is very, very poor, because there's really no collateral supplying that brain penumbral tissue for survival when there's going to be a delay of care. Whereas if someone, and this would be considered moderate, where you can see some branches here. This is where you have an you have an MC occlusion on the left side, and you can see that there is some branch filling distally, and this is good collaterals where you can see again an M1 occlusion here, but then more distally, superiorly, you see that it looks like as if it was a normal filling CT angiogram. These are the patients who really benefit the most in regards to they're at risk for infarcting a large percentage of brain. They get hypotensive or they have issues, they go on to infarct. But if you are able to recanalize them, then they have great clinical benefit and good outcome. The other recommendations is really stroke systems of care. It's what we're doing on a city by city, county by county, state by state, and a national level. It's really promoting the concept of stroke system care where you have primary stroke centers, comprehensive stroke centers, to equip and facilitate local areas to say who can best provide stroke care in a logical, algorithmic way to say that we can give IVTPA timely, and also determine who would benefit from mechanical thrombectomy if indicated. And that really requires people like you guys becoming educated in this area and to really become advocates and champions in your individual respective institutions to say, why is there such importance in this? And because it takes a team. It takes not only a team within the institution, but we have here in Hawaii, you're going to have Dr. Matt Koenig speak on telestroke later this afternoon. I purposely left out his picture here because I didn't want to embarrass him, but I have many articles of him being represented as the champion in our community. He truly has been. He has been the chair of the Stroke Coalition in Hawaii, and he has really created a bond among the different hospitals to say, it's not about where the patients go to for hospital revenue or benefit for the hospital's benefit. It's about the patient's benefit. How do you create a stroke network of care where if my mother, my father, my family member goes to one hospital, will they be able to receive the appropriate neurological care and expertise that they would have at this facility or at another primary stroke center or a comprehensive stroke center? And he's advocating that to create a network of hospitals to be able to provide the utmost highest level of care in that perspective. So when you see him, give him a hug. He deserves it. So I want to share a little bit more cases just real quick. So this is a 64-year-old male who ran out of anticoagulant on atrial fibrillation. When this follow-up work, how often do you guys see that? Someone who decides, I'm out of Coumadin, I'll pick it up next week, and lo and behold, they're in the ED being aphasic, right hemiparesis. This person has a clinical syndrome, left MCA syndrome. This is CTA axial view, and what we notice is that there is this M1 segment is really not filling, but collateral flow, there's collateral distally. So, okay, this is a person that really, really could benefit this individual. So this is the common internal carotid artery, and then M1, and M1 is completely occluded, actually distal ICI, I should say. You don't even see the ACA anymore. So we put a microcatheter up, go distal to that. And this is before and after, where we were able to recanalize the distal supraclinoid ICA. And the individual's MRI, small little spots in the basal ganglion caudate. Case 3, 60-year-old male tourist. He was from Australia, was at the bus stop, lost consciousness on the bus, was admitted to one of our sister hospitals, got IVTPA, but was still was posturing. Okay, and the patient was then transferred to our facility. Patient at the outside facility had this CTA. This is a coronal CTA view, and this is the basilar artery, and you see nothing here. So this gentleman who has come with his wife all the way from Australia Australia to enjoy the beauty of Hawaii is now comatose from a basilar occlusion. And despite giving IVTPA, and we're glad he got IVTPA, he wasn't getting better, so they transferred the individual to us. And this is the angiogram. This is a right vertebral artery AP view. So vertebral artery, basilar, mid-basilar, occlusion of the basilar artery. We put a microcatheter beyond that. We're now in the PCA. We deployed the stent, and we opened this up. And the reason for his stroke was that he had a high-grade focal stenosis of the right vertebral artery origin. We actually had to angioplasty this before even putting up a catheter up. His MRI, after we opened him up, he was completely normal. Woke up, no stroke on his MRI scan. And that shows the power of the fact that if that clot wasn't open, this guy would have died here. And basilar occlusions have about a 90% mortality rate when they don't recanalize. And so again, we are very fortunate. Number one, I work with amazing people. My techs and nurses, and then the team of doctors here. We work as a team to be able to do this. As Dr. Nakagawa you saw earlier, and by the way, one of you guys thought I was Dr. Nakagawa. I'm so flattered, by the way. My kids think that Dr. Nakagawa has the biggest biceps of any Asian guy. So I try to be Dr. Nakagawa, you know. But in terms of people like him and the team here, our APRNs, we're able to do what we do because of you all. And so these outcomes represent the hard work that you all put in on a daily basis to grow professionally, to grow as individuals, and I just want to encourage you to continue to do that as lifelong learners. So thank you so very much.